morning, everybody. Welcome to the first Bahrain International Conference in Obstetrics and Gynecology. It is my pleasure to introduce Professor Aris. He will start his first session, and he's a chairman of First Department of Obstetrics and Gynecology, University of Athens, and Greece. Please welcome him for the first presentation. Thank you.
The maternal mortality still is a problem in obstetrics. First of all, I would like to say that I don't have any conflict of interest. And I would like to say that the maternal mortality is a tragedy for developing countries and also is a shame for developed countries. I'm not going to explain what means maternal mortality by figure, but every death after 42 days or during pregnancy, during labor, and 42 days after labor considered as maternal mortality. We know that the reduction of maternal mortality, one of the major goals in several international conference, and the Millennium Development Goals that happened in 1990, they said that they are going to reduce, they try to reduce the maternal mortality from 1990 to 2015 by 3/4. Ladies and gentlemen, I don't know if we succeed to reduce maternal mortality by 3/4. And now, in 2015, the maternal mortality is reduced by 47%, according to the WHO. But in developing regions, it's still high. It's 15 times higher than in developed regions. So we do have many things to do. We know that between 1990 and 2015 was a drop by 47%. And we see the difference when we saw that in 1990, deaths were 500,000 women died every year. And in 2013, this number reduced to 300,000 women. But, ladies and gentlemen, why this happened? We know that almost all maternal deaths, 99%, occur in developing countries. And this is very important, and we have to count on that. And also we know that in 2015, in developing countries, the maternal mortality was 239 per 100,000. In developed countries, you see the huge difference between these two different regions is 12 per 100,000 pregnancies, and large discrepancy between countries, within the country, between women with high and low income, and those women living in rural or in urban in areas. So we know that the 10 top countries with the higher maternal deaths, first of all is Sierra Leone. It has 1,360 per 100,000 deaths. And we come down to Congo Republic, Democratic Republic, who is 693. You have to consider that in Europe, maternal mortality is 5 or 10 per 100,000 deliveries. So, what happened with a mother's death? This has a domino effect in developing countries, because women die, then the children, they don't have good nutrition, they don't go to school, the survival rate decreases, there is an impoverishment of the family community and the community, and there is a loss of productive by 15 million So, ladies and gentlemen, in every woman who dies, 20 more women have a seriously injured and disabled. And the maternal morbidity, which is very important, is because of the genital lacerations, urinary erectile incontinence, obstetric fistulas, inflammatory pelvic disease, genital prolapse, and sterility. And, that means that 9 million women suffer from some type of injury that can have a profound effect on their lives. But what are these women dying from? We do have only estimates, and this is very important, and we have to solve this problem. Measuring the maternal mortality accurately is very difficult because information about deaths are not very accurate. Pregnancy status at the time of death is not very accurate. A medical cause of death is not very accurate. So, ladies and gentlemen, we don't know yet why women die. What we know is that to determine the maternal mortality, you need informations. You know that 88 countries lack of complete data. 27 countries have no data at all. 65 countries have complete data. But over 80% of all births occur in countries where the maternal cause of death don't exist or is incomplete. So, we need data. And better data means designing better intervention and programs, monitoring maternal mortality trends, and also accounting for individual deaths. So, better data means better maternal health. To effectively address the maternal mortality, first we need to find out what women died from. And we know that 20%, 27%, the cause is severe bleeding. 14% is pregnancy-induced hypertension. 11% is infections. 9% and 8% is abortion complication and obstetric labor causes. And 3% is blood clots. So the main cause of death is severe bleeding and hypertension. But why the obstetrical complications of pregnancy and delivery are not all predictable or preventable, they are all treatable. And this is important. Can be treated by a professional health worker. And nearly 2/3 of maternal deaths are due to hemorrhage, obstetric labor, eclampsia, sepsis, complications for an unsafe abortion. Most maternal deaths are preventable, as I said. Deaths caused by infection and hemorrhage during pregnancy can be prevented by drugs and transfusion. And also women who need emergency obstetrical services can be transported to the nearest facility. And down there you see a picture how women are transferred in some part of Africa. In high-income countries, virtually all women have at least 4 antenatal visits. In 2015, only 40% of all pregnant women in low-income countries had the recommended antenatal care visits. So, to do a reduction of maternal mortality by using skilled attendant at all deliveries, easy access to emergency obstetric care, safe transportation for life-saving emergency obstetric care in time, and the access to contraceptive services in order to reduce unattended pregnancies. So the most widely available progress indicator in the proportion of women who deliver with the assistance of a skilled attendant. And good thing good information is that the use of skilled attendants has increased in more regions nowadays. And you see that some areas between 1990 and 2003, and now it's better, there is an increase of the pregnancies that they are attended by skilled persons. So factors that prevent women from receiving a care during pregnancy and childbirth is the poverty, the distance, lack of information, inadequate services, and cultural practice. You know, almost half of maternal deaths could be avoided, and this is very important to understand. If the people who attend the birth wash their hands, it's incredible. And also, there are the 3 delays, and especially in Africa, this happened. Delay of decision to look for skilled attendants, delay to arrive at the medical center, and delay to receive the adequate assistance at the medical center. So, what happened in Europe? Why we are concerned in Europe about maternal mortality, since in Europe the maternal mortality is very low. But there are some serious difficulties, even in Europe. The prediction of which pregnancy will have problems have failed. We don't know yet. Screening tests for prenatal diagnosis are into widespread use without evaluation, and are used for non-well-trained people, doctors. Birth, as seen medicalized, and technology used as giving birth to more interventions. It is no longer known what normal delivery is. This is why the cesarean section is very high. In Europe, we do have the Peristat, that was a group of from different countries that they look at the statistics in perinatal medicine. And what we found that the highest mortality rate during pregnancy and childbirth occur in Eastern Europe, while the lowest southern countries like Spain, Italy, and Greece, followed by those in the Southern Europe. But the problem is also that the mortality during pregnancy and childbirth is 2 times higher in women over 35. And this is a problem that we have to concern in Europe and also in all developed countries. So if you compare mortality rate between women over 35 and between 25 and 34 is 3 times higher in women's there. Also, only 11 countries provide information on method of delivery and mortality. 21 countries have provided information on morbidity of pregnant women during pregnancy. And also the main cause of death from any known direct obstetric complications remains bleeding during childbirth, is 13.1%, thromboembolic events, and hypertensive disorders. You see, in Europe, hypertension is the 3rd cause of maternal mortality. So, what about teenage pregnancies? Ladies and gentlemen, you know that WHO estimates the risk of death following pregnancy is twice higher than if the pregnant woman is not in teenage. So the highest incidence is in Afghanistan, and also there are 13 million adolescent mothers and 70,000 deaths. Also, sorry about that, but I have to change both slides. So, concerning the abortion and unwanted pregnancies are a serious threat to women's health. There is no doubt about that. And even where abortion is legal, its potential side effects account for a major proportion of maternal mortality and maternal morbidity. Let's say that I give you some figures. There are 211 million pregnancies every year. There are 46 million end in induced abortion. 60% are carried out under safe conditions, but 40% under unsafe conditions. There are 18 million induced abortions each year are performed by people lacking the necessary skills or in environment lacking of minimal medical standards, or both. So there are 68,000 deaths every year from abortion. So how we can solve the problem? By contraception. So if we want to save mother's life, we need political will and commitment, contraception and safe abortion services, strong health system, improved access to quality care, health and well-being, and efforts to reach everyone, everywhere. So, ladies and gentlemen, now, between 2016 and 2030, as a part of Sustainable Development Goals by WHO, the target is to reduce the maternal mortality in cases of less than 70 per 100,000 births. Remember that in some parts of Africa is 1,360, like in different countries. So during the United Nations General Assembly in 2015 in New York, the Secretary General, the previous one, Ban Ki-moon, launched the Global Strategy for Women's, Children's, and Adolescent Health. So we have to, in this part of the world, in Central Africa, we have to reduce the maternal mortality by 70 per 100,000. So the introduction of the Sustainable Development Goals are that a set of 17 goals for the goals featured through 2030 is backed up by a set of 169 detailed targets, and also negotiated over the 2 years period at the United Nations. Agreed to by nearly all the world's nations on 25 September 2015. So, what are these 17 goals? If you look very carefully, number 3 is concerning the good health. That means that we have to ensure healthy lives and promote well-being for all and at all ages. And ladies and gentlemen, each goal is very important. And also, all these are very well connected. So we have to, in order to achieve this, we need some national policies informed by high quality, timely, and reliable data, disaggregated by income, gender, age, race, ethnicity, migratory status, disability, geographical location, and other characteristics relevant in national context. And I hope that I try to take your attention about this problem, because, ladies and gentlemen, don't forget that every year 300,000 women dies because of pregnancy. So we obstetricians and gynecologists, we have to be united and try to reduce these very serious and important problems. Thank you very much. Thank you.
Please welcome with me Dr. Baker Elmardi. He is the head of Obstetric and Gynecology Department, head of Urogynecology Unit at Royal Hayat Hospital in Kuwait. Please welcome him.
Assalamu alaikum, good morning. It's a pleasure. I would like to thank Madam Speaker and the organizing committee for inviting me to visit Bahrain. My talk is about risk management in obstetrics and gynecology. Although I'm a urogynecologist, but obstetrics is always our passion, and we still cover labor ward most of the time. Before I came to Kuwait, I worked in this hospital, and I have worked there for 13 years. And at the end of that corner, I don't know if the pointer is working. I used to live in that house, and I walk every day to the hospital. Now I work in this hospital, but every morning it's a risk to drive. And that's where you have to watch whenever you drive in the morning. It takes me about 3 hours, and on the old days, I used to take about 10 minutes. I'll be walking to my hospital. So if we talk about, I have any conflict of interest. If we look to the definition, it's a process whereby organization anticipate the potential for injuries, losses, and act to avoid those injuries before it did happen. Does any organization do risk management? Yes. Nuclear industry, aviation, chemical industry, oil, transport, finance, they all do that. Why? Because it's a high-risk industry which could have an effect in their employee, general public, environment, and their reputation, and the survivor and the profit. And obviously, you could see in that in the last couple of years, we have 3 tragedies from aviation. And you can see this pilot is looking far away, and there's a flight coming down there. And that's risk management. I think in medicine, we'll learn from aviation about risk management. Do we have any risk management in healthcare? Yes, if you look to the incident of Beverly, the nurse which killed many children, Bristol inquiry, the open heart surgery, Dr. Shipman, the GP, blood transfusion services when HIV was there, organ retention. There's so many examples that healthcare have to look into risk management. I think in the period of 1991 to 93, there's a big scandal in South Meads where they've done many surgery for younger children. If you look to Dr. Chipman, which is the GP, he nearly accused for killing more than 290 patients because he tried to be passionate to this patient. And these are all areas of risk management need to be included. If we look to the risk management, the definition in healthcare is about the group of activity which remain alert to the organization to the risk faces through identification of the risk, development and implementation of action plan to reduce harm to our patient. If you look to the Royal College of Obstetrics and Gynecology, and it's defined the risk management as a method of early identification of adverse event using either staff reporting the incidents in a systematic screening way, and that should be followed by creation of database to identify common pattern for all these risks which have been held. Is risk management an issue in healthcare? Yes, it is. If you look to the National Health Service has an excess bed occupancy due to medical error, more than 750 million pounds every year. If you look to other area of infection control, United Kingdom or the Minister of Health spent about nearly 1 billion. If you look to the nursing absentees, that costs about 700. So there is many issues of how risk management could affect healthcare. If you look to the risk, is it risky to be a doctor or healthcare? Yes, it is. If you look to the Harvard Medical School in 1991, nearly 4% of hospital admission led to adverse event. Nearly 2% of hospital led to avoidable event. And in the same time, if you look to Australian background, that there's about 98,000 avoidable deaths every year. If you look to London in 1999, University College, 8 to 10% of patients die, nearly 40% from medical errors. So we need risk management in our health service. How do we deter the error in care? I think in the United Kingdom, 10% or 1 in 10 hospital patients suffer from adverse effects. You look to New Zealand, about 10%. You look to Denmark, about nearly 10%, and in Australia. And these are statistics which show that we have to be very careful, and we have a system to manage risk management. And if you look to healthcare care errors, relevant, yes, in the United Kingdom, we have lost about nearly 40,000 patients per year who die from medical errors. In the United States, about 44,000. In Australia, about 18,000 per year who are having a problem. MBS is a defense union in 2000 have shown that there's about 1,200 people in England and Wales died direct for drug errors. And the majority of that drug error is incorrect medication or caused by wrong dose. And these are all areas where we are a very dangerous practice if we don't. And if you look to these incidents, are always a combination of incidents. It's not one failure. It's a failure of doctor, organization, nurses, and that's the failure. It is always an accident which could happen. If you look to the cost in the United Kingdom for medical legal negligence because of the failure of risk management, the National Health Service first faces a medical negligence of about 2.6 billion. About 1.3 billion claims have not yet been received. And at the same time, majority of that claim are from our specialty. Obstetrics mainly is our specialty. So what are the objectives of risk management? It's to minimize the risk to quality of service and patient outcome. We have a patient who demand a lot, and they deserve that. To ensure the provision of a safe and effective service. To confirm the service outcome reflect the plan intention. We go every day to our hospital, and we don't have an intention to harm a patient, but things happen, failure of organization happen, and it leads to that. And we want to provide a safe, secure environment for staff and patient. Ensure effective, efficient use of resources, and at the same time, we seek to learn from the mistake we've done. As an example, if you have an unsheathed needle lying on the floor, this is a hazard. If that needle have made somebody have a stick injury, this is a risk. But if somebody found the needle, took it out, and put it away, that is a near miss. And it is an incident if it is stick one of the staff. So that's an example of all what's the definition of hazard, risk, near miss, and incident. So the medical framework work for the risk management in healthcare, we need to raise awareness, design a safety, involve the user. We have to involve our patient in this setup. Collect, analyze the data so we learn from our mistake. And obviously, you always ask yourself 3 questions. What is the chance of it going wrong, and what would be the impact? This is risk analysis and evaluation. The other question, what can we do to minimize the chances, to minimize what's happening? And that's risk treatment, and in the same time, the cost of prevention compared to the cost of getting things wrong. And the last one, what can we learn from the thing that having gone, is risk control and sharing and learning from that mistakes. Obviously, the structure of risk management need leadership. For example, in obstetrics practice, clinical directors, head of obstetric, the junior, the senior obstetrician, the midwife, neonatologist, and the anesthetist. We are the team who need to form a body to look into risk management in every part of our specialty. And obviously, we need to raise awareness. And awareness will not come, we have to have training, education. It's a teamwork to reduce all this risk. And we have to have a management form for that. Communication strategy. And that's the difficulty. Always the failure in medical practice is fail of communication. So the team had to work all together. And you always have to have an appraisal and accountability for that. And obviously, organization requirement for risk management have to have integrated framework, link hospital to every specialty, and at the same time, you have to have a designated lead risk management for every specialty, from orthopedics to obstetric to neonate, and that's the only way that we could support our patient and reduce the risk of them in healthcare. How to manage risk by risk identification, risk analysis, risk treatment, risk registers, and the national context among the NHS. And obviously, risk identification is all clinical areas should have a formal process where they could act together to find out what could be, and what can we do when things go wrong. And obviously, one of the important risk management issues is medical records. And that medical records, for example, in obstetrics, documentation of admission of a patient, the partogram, going to theater, postnatal, gynae notes, these are the first element in risk management that you have to have all completion of this area and document the management of the plan. You need to look to the notes, then you need to know that this patient is going to have that and that and that. The security, the confidentiality, and always the explanation, the discussion, and the consent. We are here not to harm patients. Patients have to know their rights. So you always have to have that consent, either verbal, documented in the notes, or patient have to sign this piece of paper. And then we have to have incident reporting. We have to collect all these incidents in the organization in that. You collect the evidence, you collect, analyze, you have to have a safety culture for that, incident reporting, case net review, root cause analysis for this risk you have, and you have to have a benchmarking. What's happening in Europe, what's happening in Africa, you have to have a benchmark so as to give a right identification of the risk and how to improve it. We need to involve our user. Every organization has to have the user being involved because we are there, we come every day to help these users. So we have to involve them and we have to make them aware of the hazards in their care path, make it the patient safety intervention is very clear for them, reporting patient safety incidents, and feedback the safety care. They need to know what we're going to do. And then obviously to design the safety, you have to look into your standardization from your guidelines, from your protocol, effective communication. You have to look into the care bundle of that patient in that organization. The handover, the debriefing, that is part of continuous care for this patient. And obviously, we have suggested lists in obstetric and gynecology. We look to this risk and then we identify it. For example, undiagnosed breech, shoulder dystocia, blood loss more than 5. These are the things which we look into, which happen every day in the labor ward. If you look at the neonate, maybe more than 4 kilos, neonatal deaths, we have to report that. 3rd degree, 4th degree, you have to identify that. You have to do your audit to find out the statistic. Organization failure, there is faulty equipment. Sometimes you go to the theater or your gas is not working. These are the incidents which will happen. Then you need to target this incident and find out why that's happening. You look to other incidents, maternal incident, for example, women who are having venous thrombosis, pulmonary embolism, 3rd degree, 4th degrees. These are the area where you have, these are suggested incidents have to be collected. If you look to the area of gynecology, you do a hysterectomy, you injure the ureter. This is an incident. You need to know what's going on. There's so many examples, medication errors. That's failure of organization. So these are topics which you have to address when you're collecting the evidence of what went wrong. If you look to also gynecology, so many times doctor nearly struck off because they did a hysterectomy and they removed the ovary without a consent. And that is now is a serious, so these are areas where you have to look, identify, and then find out how could we reduce that. Unplanned return to theater, yes, that's an incident, you have to look into that. And obviously you have to have a register for all these risks. And the risk register is a database to identify where is the risk and how could we address that. Its purpose to help managers to prioritize the available resources so as to minimize risk in the future. And then you measure the risk, the likelihood, the consequence of having a serious incident. And you can see here assessing the risk, that the risk category is like low, minor, moderate, severe, and catastrophic. And you look to the quality of that. Sometimes catastrophic risk lead to growth failure to meet professional standard. That's why the care fall below the standard of care which an average clinician would do. And that could lead to public inquiry. Recently in the United Kingdom, there's 2 or 3 hospitals have been having a public inquiry because after many years of practice, they found there's so many deaths, neonatal, maternal, and some of these hospitals have been not closed, amalgamated, and changed the hierarchy for that. So it's very important. And then there is prioritization matrix, where you look into what are most certain, likely possible, and compare it to, is it moderate, is it severe, and you need your risk management team have to look into these practices. If you look at the risk management cycle, it's about initiation, identification, and assessment, reporting, monitoring, and management of that risk. Obviously, you have to look into what went wrong. How do you do that? By these key steps: identify the incidents, select members who look into that investigation, collect the data from the record, describe the chronological incident, what went wrong in chronological order, identify the delivery of that problem, identify the contributing factor which lead. Sometimes inadequate training. You have your registrar who go to the labor ward and never had done a forceps or done a vacuum. And that's failure of training. So you need to identify that so as you could address this and devise an action plan. If you don't do that, we are failing our patient. And obviously, we have to learn from our mistake. Yes, we are human beings. And that has to be carried all the way to the board level so they could address all these incidents, look to the feedback from the analysis, learning from that, develop evidence base for safety intervention. So you have to have protocol for that. So risk management overview is about establishing the context, identify the risk, analyze the risk, evaluate the risk, and treat the risk. That's the cycle of risk management. Most errors go unnoticed or underreported. The majority that we didn't notice that, and you could see in that big snow. No doctor or nurse come to work to harm patient. That is the very last thing that we come to do. Our intention is always to help, but mistakes happen. And the problem is that when we have a mistake, we feel shame, we have fears, self-doubt, isolation, and sadness. So the dilemma is that patients clearly want to talk about the adverse effect. Doctors find it difficult even to see if there is an error. That yet is ineffective to handle outcome, can improve patient safety and reduce litigation. And that's the problem. Do patients want to know? Yes. Patients, at least 98% of statistics have shown that patients want to know and told the truth. You cannot hide. And that's why risk management does not finish here. You have to have an open disclosure. We have to own to that patient. We go, apologize, tell the truth, and that's how patients, they look highly about us when we are honest. Patients are not there to blame us. If you look to the principle of open disclosure, it's about acknowledgement, truthfulness, apology if appropriate. There is no harm to say I'm sorry, but that does not acknowledge that I made a mistake. But a complication has happened, and you have to report that incident. And show professional support for this patient. It's a risk management will be improving by if you have disclosure for any problem. It's a multidisciplinary responsibility, it's clinical governance, it's confidentiality, and it helps in continuing the care. I'll quote some form of patient advocate. It's an open disclosure. It's not about the blame. That's patients are saying. It's not about accepting the blame. It's not about opportunity the blame. It is about integrity and being truthfully professional. And the reason you hold our life in your hand, and we as a patient want to hold you high in regard. That's what patients think about us. So, method of identifying the failure is about monitoring the number of the complaint, the critical incident survey, and patient satisfaction survey is very important. In conclusion, clinical risk management has close link to the development of a good, effective clinical practice. It is mandatory to develop reporting question system to identify failure of quality. Patients deserve high quality. And in conclusion, To err is human, to cover up is unforgivable, and to fail to learn is an inexcusable. Thank you very much. That's Kuwait at night.
Thank you, Dr. Abu Bakr, for this very interesting and very actually applicable presentation that we have nowadays, and we are facing it. It's really a very informative presentation. Now we still have a time if anybody wants to have a question for Dr. Abu Bakr. Is there any question for him?
They've learned all the risk management now. Thank you.
Thank you, Dr. Abu Bakr. We'd like to have our next presentation.
So next presentation is by Dr. Chalouhi. How you pronounce? I don't know. And he's going to talk about fetal surgery, the state of art in 2020. It's a very important issue and very important topic.
Yes.
Please.
Thank you very much. Thank you for the presentation. I want to thank the organizers, Dr. Naima and Dr. Rizq, for the invitation. It's an honor to be here with you. I am Gihad Chalouhi. I am an OBGYN, Lebanese OBGYN. I specialized for 10 years in France with Professor Yves in fetal surgery and came back 2 years ago to Lebanon to start a fetal surgery center, and we're trying to do some collaborations in the region, and hopefully we can set something with you here to build afterwards maybe an independent fetal surgery center in the country. So fetal surgery is something that is not very new, but it's becoming an active field and a developing field. With the ultrasound that we are doing nowadays, we are the performance is very good, the images are amazing, the diagnosis is becoming more and more precise, and we're getting the right diagnosis in a perfect time to treat this baby. So the fetus has become a patient, and we have now the ability to do some anatomical and functional imaging, not just with ultrasound, with MRI. And you can see here some diagnosis for the pointer works, but at small range. Muhannad. It's not working. Okay, so it's not working. So you see here a diaphragmatic hernia on the left. You have it is teratoma on the right, and once we do our diagnosis, the most important thing is to offer some treatment. And now with fetal surgery, we can offer treatment for some patients or some fetuses. So we go in utero and we do in utero surgery. This is a fetoscopy where you go in and you see this fetus with this. With quite amazing. This is a journey. It's like science fiction, but it's becoming more science than science fiction. And it's a boy. So we won't talk about diagnostic procedures like amniocentesis or CVS, although this is commonly done. We won't also talk about fetal therapy like in utero transfusion. This has become a common practice, and it's quite simple compared to to fetal surgery, where you administer in fetal anemia cases like rhesus anemia or alloimmunization. You transfuse the baby in utero a couple of times so he can survive the prenatal period and survive the antibodies from the mother. What we will be talking about is fetal surgery. Not every pathology or congenital abnormality we diagnose, we can treat. There are some standard consensus about who to treat, when to treat. So first we have to know the history of the pathology we have. This pathology has to be lethal if untreated in utero, or has severe morbidity in untreated cases. There should be a partial or complete pathological correction, and the therapy we are using is validated. You cannot try anything at home if you feel like it. And what is very important in fetal surgery is that the intervention we're doing is aimed to transform a lethal pathology into a normal survival. We don't want to transform a lethal pathology into a severe handicap, because this is counterproductive, and this is not the point of what we are doing. So these are the different pathologies that can be managed by fetal surgery. Some are cured. So the ones on below are cured by fetal surgery. We will talk about twin-to-twin transfusion syndrome mainly. And those that are above, it facilitates postnatal treatment. And you will see in, for example, congenital diaphragmatic hernia. If we do the fetal surgery, this baby can survive to be operated at birth. Otherwise, his lung would be hypoplastic and he won't even breathe at birth. So these are the main pathologies that we can treat, and I'll show you a couple of examples. It will be like an overview just to see what we can do. When we're trying to operate the fetuses, Muhannad, Haydi hiya. You're good? Okay, so we always have to take into account the fetus awareness. So there's anesthesia first, so he doesn't move, but also so he doesn't feel pain. So this is given before every fetal surgery where we are in direct interaction with the baby. This we see here, some anesthesia given in the umbilical cord insertion under ultrasound guidance. So these are the different systems that we can work on, and we'll start with the placenta. This is the most commonly done intervention, and which has been validated by a randomized controlled trial. We know that placenta is the tree of life and it's magical, but when it becomes intricated and you have two fetuses sharing the same placenta, like in monochorionic pregnancy, we know that there are vessels passing from one side to the other, which can lead to some specific complication of monochorionic pregnancies due to the exchange between these two fetuses. And this exchange will lead to these specific complications of monochorionic pregnancies: selective IUGR, twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, and sometimes to the death of one twin. This is in brief, twin-to-twin transfusion syndrome has a 10 to 15% occurrence, so it's 1 over 5 almost that will have this complication. We don't know yet the clear mechanisms that lead to twin-to-twin transfusion syndrome, but we know that we can diagnose it early by a discordance in nuchal translucency and cardiac function. So there are plenty of things that we can do to diagnose it early and treat it in proper time. What is very important to keep in mind is that the natural history of twin-to-twin transfusion syndrome is 90% mortality. If you diagnose twin-to-twin transfusion syndrome, you don't do anything, you lose both babies, which is quite dramatic. There is a Quintero staging system I'll show you now, and once you diagnose it, you have to treat it. It's an indication for intervention. So no need to see which one needs intervention or not. Till now, it is validated that intervention is for all stages of Quintero staging until further notice. So once you do the diagnosis, you can see here on the right, once you put your probe, you know this is twin-to-twin transfusion syndrome, but the criteria are on the left. So you have a deepest vertical pocket more than 10 in the recipient, and the other one has less than 2 centimeters of deepest vertical pocket. Or he can be stuck, or he could be in anamnios. So these are the criteria. They're very simple. You see here the bladder of the recipient is full and he has a very big pocket, and the other one is stuck on the side, no fluid, no bladder visible. Sometimes people confuse it for monochorionic monoamniotic because they did not do the diagnosis before. You see him, this is the stuck twin. Once you do the diagnosis, you have to treat. Earlier on, we did amnioreduction, multiple amnioreduction, and then at some point, Professor Yves validated in a randomized controlled trial the benefit of doing a fetoscopy, fetal surgery for these pathologies. So there were randomized patients between amnioreduction and laser, and this trial was stopped early because it showed clear benefit for survival of at least one twin, with a great benefit for laser, for outcome also, and for gestational age at delivery and neural impairment after 6 months. And now it's validated for more than 6 months. But this is the trial that changed our lives and changed the lives of these twins also. It's not very complicated. It's not costly as an intervention. The material is also, it's the normal laparoscopy colon. The only new thing is this laser machine, the blue one. This is a new thing. It's not costly, so it's quite tight. The competence is the difficult thing to acquire. When they first started it, this is Nicolaides with Professor Veal in London doing that. So they used to do it in the clinic. Now we do it in the OR. So you can't imagine the number of bacteria on just this curtain. So we're trying to be more sterile. We do it in the operating room. Not much tools required. This is the scope and the instrument that we use. It's a transabdominal access directly from the belly of the mother with ultrasound guidance at first. And we introduce with ultrasound guidance, so this is the entrance of the trocar. I'll skip that. And then we go in with the scope. So the scope is direct visualization of the fetus and of the placenta. Here you see this is the fetus that you are seeing at the level of his head. And then you will see, for example, this is the donor. He is a stuck twin. So when we will arrive at the level of his hand, you will see his hand taken into the membranes. And we always go into the sac of the recipient because he has a lot of fluid. This is how we see the different thing. The recipient, the donor is stuck above, and underneath it we see the placenta and the vessels. So when we go in, we see these vessels and we can work on coagulating them. Here you see the membrane separating between the two babies. The membrane that is folded, this is the equator. And then we coagulate these vessels that we know are present systematically in twin-to-twin transfusions, in monochorionic pregnancies. And we coagulate them like these ones to try to separate and transform this monochorionic into something like a dichorionic pregnancy. To coagulate them, either we go non-selective, so we look at the membranes. Every vessel that is passing, we coagulate it. This is non-selective. Or we follow the different, we follow the different vessels, and we see which vessel is communicating with another one, and we coagulate it at the level of the anastomosis. Press play. Okay, so here you see the vessel, and we coagulate it with the laser. The point that you're seeing up in the screen is the laser fiber that is coagulating the vessel. This is non-selective coagulation. The selective coagulation is when you see where the pointer is. You see how the vessels communicate with each other, and you burn it at the level of the anastomosis, like in this video. We follow the vessel, you see this one going on, and here this is a connection with another vessel coming from the recipient. So at this level, we will go with the laser fiber and coagulate it selectively. We are sure that this is in anastomosis. The prognosis in brief, like I told you, 90% loss if we don't do anything. With the fetoscopy, we are able to have 80% survival rate of at least one twin. So there is no way of imagining another solution than to do this intervention to save these babies. Now, of course, when we say 8% survival of at least one twin, it means 50% both survive, 30% one of them does not survive. But it is still something that is worthwhile if you compare it to 90% mortality. So this is one of the randomized studies that changed practice. The other one, you all do it. It's the corticosteroids for lung maturation. This is another one, so we should always also all do it. For the lungs, This is another pathology that has been operated, and it's mainly diaphragmatic hernia, where we have a hernia, a defect in the diaphragm, so you get the bowel that goes up into the thorax and hinders the development of the lungs, which can have a high mortality rate. We have some criteria to see which diaphragmatic hernia we operate, which are not worth operating. And when we go get these criteria, so it's lung to head ratio on ultrasound and observed volume of the lung compared to expected on MRI, we do fetal tracheal occlusion. So we go into the trachea of the baby, we put a balloon in order that the secretions accumulate in the lung and do a counter pressure to the pressure coming from the bowel. So the baby will have lungs developed when he is born. We do that 2 interventions for now. We put the balloon at 26 to 29 weeks, and we do another intervention around 34 weeks where we go in and we remove the balloon. This is schematically how it's done. We put the balloon and we go out. The tools that we use are the same that for twin-to-twin transfusion syndrome, and this is how small the balloon is. And Muhannad? Yeah. So practically we go into the belly and we intubate the baby. So here we are going into the mouth. Okay, we try to intubate it, and then we want to follow the different landmarks to go into the trachea. Now we are going into the mouth, and you can't see my pointer, neither can I. This is the lung that you are seeing. So once we see the lung, we go to the veil upwards, and we see the white line that you're going to see now is the midline. So we follow it up in the palate of the baby until we get to the uvula in the posterior. Okay, so now we're going to follow it. The movement is a bit slow, but you can imagine the precision that you need. So we follow this white line. The baby is anesthetized, so he doesn't move, he doesn't swallow when you're doing that, otherwise you cannot operate. We're following. This is the uvula that you're seeing. Now you're at the level of the larynx. We will move a bit forward, and we will see the epiglot. So we have to go and move this epiglot in order to expose the vocal cords and go in between. Because now we're looking in the esophagus. We move a bit anteriorly, and you'll see now, we begin now pushing, and you see the vocal cords are opening in front of you, and we are pushing the epiglot. These are the vocal cords opening, and we go in. This is the trachea. Okay, we intubate. Now we have intubated the baby. We go down until we see the carina, and at the level of the carina, we will push a small balloon and inflate it. Once we put it in place, we leave it in place for 6 to 8 weeks, depending on the response of the lungs, and then we go in to remove that balloon. Can you move it a bit forward, Muhannad? Yes. So this is the balloon being inserted here. A bit more. Muhannad, a bit more. Okay, so this is the balloon being inflated, and then we leave it in place. So here, the balloon. Afterwards, I won't show you the video to remove it, but we do the same procedure to remove it. We go in, we hold it, we puncture it, and then we go out. So it's practically the same intervention that we do 6 to 8 weeks afterwards, depending on the response of the lungs. Okay, just waiting, so we will go back a little bit and with the scope. Well, here. Okay, so you see the balloon is in place, he's stuck, we're going out of the trachea. You will see now the vocal cords closing, and we will go out of the mouth of the baby, and this is the procedure. Practically, it's like 10 minutes. It's not too far, but it's technical for preparation, and this is his, you see both his lips and the nose, and he's happy to see you too. So this is the intervention afterwards. You see the lungs have taken a good volume, and you see in the lower right side, this is the balloon, how you see the balloon on ultrasound. And to remove the balloon, we go in and we do another intervention to remove it. I won't show you the video because it's too much. This is the first one that we did in Lebanon. Meet Jawad. He's 1 year and a half now and doing fine. Another pathology of the lungs that can be operated is compressive pleural effusion. So it's like in adults, you put a drain. This is what we do. We put a shunt when this compressive pleural effusion becomes vital. We go in, anesthetize the baby, put a drain into the thorax. We put it on the posterior side in order that the baby does not remove it on his own. This is how it's done on ultrasound guidance. So we go in, we puncture it, we leave it inside. This is a life-saving procedure also. If we do it, most of the time he will have a very good survival afterwards. But we just have to pass this compressive. Another compressive pathology of the lungs can be sequestration or teratoma. If it becomes very big and compressive, we can operate it and under ultrasound guidance and coagulate the vessel irrigating this mass, like in this one. So we go in with the needle and the laser fiber, and we puncture at the level of this vessel and we coagulate it. We have some data on these surgeries. Of course, these are do not do that at home, but this is what we can offer to these babies. We have the resolution of the eye drops and this mass that becomes a lot smaller. For lower urinary tract obstruction, there are plenty of pathologies and some treatment that we can provide, either by putting a shunt, like in the thoracic problems. And this shunt is put between the bladder. It's a vesico-amniotic shunting in order to relieve the pressure at the level of the bladder. And this is the shunt when the baby is born. Once he is born, you remove the shunt and then you treat the pathology that was there. In some occasions, we did fetocystoscopy, or sometimes we go in to work on when you have a ureterocele that is compressive, that is blocking the bladder. This can be a lower urinary tract obstruction and induce renal failure. We go in also with the laser fiber here, and we are opening this ureterocystocele in order to relieve this obstruction. We published a small series about these cases with a very good outcome for the babies. For the heart, we have small interventions also, but in severe cases of aortic stenosis or pulmonary stenosis, where we go into the heart. This is a video, Muhannad, and we catheterize the vessel that is stenotic, usually the aortic stenosis, and we dilate it with the balloon, like an adult, like an angioplasty. For the limbs and amniotic bands, sometimes you have some amniotic bands that are constrictive, which can lead to amputation of limbs or sometimes cord constriction. So in severe cases, not all cases, we go in to operate. You see here on the upper right side, he's starting to lose his finger, and on the lower left side, you see that the vascularization of the leg is not proper anymore. So if we leave it as it is, he will lose both his legs. So in such cases, we operate and remove the amniotic band striction, either with laser or scissors, and the result is quite acceptable. He still lost a couple of toes, but he has his 2 feet. And we published also a series about plenty of cases operated, and the result is good. As you can see him dancing here, you should have seen him. So it's functional. He has 2 lower limbs and 2 functional lower limbs. He still has the scars, but he's doing fine now. I won't talk about myelomeningocele too long, but you all know that it is validated now that the therapy in utero surgery for myelomeningocele is validated. Now, it is difficult to be reproduced because the surgery is open surgery for the uterus, and the baby is not cured. You gain some levels of defect and less indications for ventricular shunting, but the baby still has, most of the time, the repercussions of spina bifida. So, as I said, randomized studies that changed practice, corticosteroids and the fetoscopy for lung, for twin-to-twin transfusion syndromes. For myelomeningocele and the surgery for diaphragmatic hernia are a bit more difficult to install because it's complex surgery, it's difficult, and the reproducibility is sometimes difficult to do. Whatever fetal surgery you want to do, the mother comes in first, so we always take into account her well-being. For now, there hasn't been any severe complications for the maternal complication. Of course, there are some infections, some miscarriage, some hemorrhage, but no maternal death till now. We still keep these criteria in order to operate, and keep in mind that when we want to operate, we have to transform a lethal pathology into a viable one and not transform it into a severe handicap. Thank you for your attention.
Thank you, Dr. Gihad, for this presentation. It's really interesting, and I know sometimes it's really difficult. You need to have a proper place with all the equipments. Most likely should be in a tertiary center.
Yes.
I might have one question for you.
Please.
Now, in a setting, like if we have a twin-to-twin transfusion syndrome where there is no feasibility of laser surgery, is there a place for amnioreduction still?
This is the second best thing, but now you have me, so there is a place for fetal surgery. You have to send them to me or I come do it. Otherwise, there is no other solution than amnioreduction. But while doing amnioreduction, the survival rate is 50%. So they are born earlier and with the repercussion, because you do not cure the problem. You just remove the symptoms. So the mother hasn't anymore the hydramnios, she doesn't feel the pain, the contraction. So you delay a bit the birth, but you increase the risk of premature delivery because we are puncturing a couple of times, infection. So the results are not good. So, but if you don't have any other solution, this is the best thing to do.
Thank you. Is there a, yes, please. There is a question by Dr. Abu Bakr. Is there a...
Hello, Dr. Gihad. It's really fascinating.
Thank you.
What you have said. It's very impressive. I always say that medicine have changed because of two things, in ultrasound and endoscopy.
Yeah.
I could see from your presentation that what is the learning curve for a surgeon like you or a physician like you?
Yeah.
And the other thing, you didn't talk about mortality, failure of the operation goes well. So could you elaborate on that?
Of course. So the learning curve, you have to be in a center where they do these. There has been some studies that were published, and you need to do around 70 interventions to be able to do one on your own. So you have to be in a big center that does that has a load. You can, even in Lebanon, for example, we should have around 60 per year if they arrive statistically, but we do around 20, which is a bit something to improve. So you cannot learn in a small structure. Where in Paris, for example, where I was with EFIL, they had the National Referral Center. So they did around 250 per year. So if you do around 1 or 2 years over there, you will get enough load to see enough, then do a couple before you can do them on your own. But the learning curve is around 70 in order to have the competence to do these twin-to-twin transfusion syndrome and the congenital diaphragmatic hernia. The others have other different curves. Concerning the mortality, as I said, for the mother, there hasn't been any mortality for now, thank God. For the babies, for twin-to-twin transfusion syndrome, there is a 20% loss, which is compared to the 90% loss is not much, but there is 20%. So when we counsel the patients, we tell them we have no other choice than to go with this surgery, but 1 time out of 5, we lose both babies. But if we don't do anything, 9 times out of 10, we lose both babies. So people accept this solution, but they know that in all interventions, there is still some margin for loss of the baby or the babies, both babies.
Thank you. Is there any question for, yes? We have a question there. Can you?
Thank you for a lovely presentation. I just want to know which twin is more at danger of dying, the donor or the recipient when you are doing this procedure?
Can you repeat the question?
The donor or the recipient, which twin dies more frequently during these procedures?
Okay, this is a bit complicated because there is, in twin-to-twin transfusion syndrome, sometimes there is a selective IUGR that is combined. So if the donor is smaller, he has bigger chances or higher chances of not tolerating the interventions. Otherwise, if they do not have a growth discordance between them, they have almost similar risks of dying, because the recipient also has a hypertrophic cardiomyopathy, because he's pumping for a very big volume. So most of the time he has a hypertrophic heart, tricuspid regurgitation, sometimes pulmonary stenosis. So when you change all the hemodynamic by cutting these vessels, you change a lot for him, and sometimes he's not able to cope with this change. So sometimes it is him also that does not tolerate the intervention. But if we take it globally, the donor has more risks of not tolerating the intervention. Now, one other thing, usually we think that when we're at stage 4 and you have a high drops, that this should not be operated. This is one of the things that is not true, because if we do the intervention, even if we are at stage 4 and the recipient has a high drops, you have a reversal of this high drops and good chances of survival. So I hope I answered your question.
Thanks.
Yes. We have another question there.
This is for Professor Abu Bakr. Thank you very much for the nice presentation about risk management this morning. My question, for unreported nearly missed cases, which is usually the tough part of any risk management process, what is the tool you can suggest to improve the reporting for nearly missed cases?
Yeah. I can't. Oh yeah, I mean, you need to, as I said, make awareness in your department. You need to set up a team, which what we call the local risk management team, and obviously to develop, for example, in obstetric practice, you need to involve your obstetrician, your midwife, your neonatologist, your anesthetist, so as you have at least a monthly meeting where you pick all this. And then you have to have a risk management staff who collected all the complaints, because how do you know about these incidents is by patient will complain about that happening. At the same time, you have to look into what I have suggested from the protocolate. For example, if you have reported cases like blood transfusion, pulmonary embolism, you need to keep this incident and you investigate that. So you have to develop a team to having the risk group in your department. That's the advice I could give.
Thank you very much.
There is a question. Mehraj, there is a... Just a note, if you have any question for the three presenters, please feel free to ask any question to any one of them. Yes.
Thank you very much, Dr. Gihad, for the very nice, interesting lecture.
Can you speak on the
I want
microphone?
to ask regarding the consent and counseling of the patient. Did you find any ethical difficulty when introducing that service?
I did not.
Regarding the counseling?
Yeah.
Yes, and consent? Have you noted, did you find any difficulty when you're introducing that treatment?
the question is, did I get any difficulty in getting the counseling and consent?
Yeah.
Okay, for the counseling, you get with experience. Once you spend 10 years doing this counseling, you know how to talk to these patients and how to counsel them. Now, most of the time, when you suggest a solution for someone that has seen 5 doctors who told him you will lose your pregnancy, there is almost no need for counseling. They for consent, so they are willing to do anything to save these babies because they have 90% of losing both twins. Now, we always counsel them on the basis that we said. So I tell them, for example, for twin-to-twin transfusion syndrome, I tell them 5 times out of 10, both babies survive. 3 times out of 10, one of the babies does not survive. And 2 times out of 10, we lose both twins. We have to, before we start any fetal intervention, any fetal surgery, I tell them that this is the only option we have, but this might not work. But what we are doing is the best that you can do and the best that medicine can offer. We can do. Sometimes we have some limits in the things we can suggest and the treatment we can do for patients and for fetuses, but this is the best that we can offer anywhere in the world. So they know when they go into this intervention that there is a possibility of failure. And for diaphragmatic hernia also, I tell them we see how the baby responds, we do the best we can, depending on the criteria, and we have a better survival rate and a better lung volume, but sometimes it's not enough when the baby is born, it's not enough for him to breathe and to survive. So patients know that this fight they are doing is sometimes, most of the time we win, but sometimes we have a loss, and what we would have done would not have served to anything, but they will be relieved that they offered the best possible things for their fetuses or children.
Any question? Thank you, Dr. Gihad.
Thank you very much.
Thank you. I think there will be just 5 minutes, just preparation for the official ceremony, which will start at 10 o'clock.